Welcome, everyone, to today's webinar. Advocate Aurora Health builds resilience with workforce management strategy, sponsored by Simpler. I'm Brian Zimmerman with Becker's Healthcare. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's now my pleasure to introduce today's presenters. Today we are joined by Dr. Mary Beth Kingston, Chief Nursing Officer at Advocate Aurora Health, Margaret Gavigan, Regional Chief Nursing Officer and System VP of Clinical Operations at Advocate Aurora Health, Dr. Jane Dews, Regional Chief Nursing Officer and System Vice President of Nursing Education and Professional Development at Advocate Aurora Health, and Dr. Carlene Kerfoot, Chief Nursing Officer at API Healthcare Simpler. At this time, I'm pleased to turn the floor over to Dr. Kerfoot to begin today's presentation.
Thank you very much, Brian. We're very pleased to be here today and to be able to talk about balanced outcomes as a way to be able to get effective staffing. And we are very, very happy that our colleagues from Advocate Aurora have volunteered to join us today to be able to share their success story and talk to us about how they've been able to work with technology and outcomes to get where they are today. And as you well know, Advocate Aurora is a very well-respected organization that has great outcomes, and we are very pleased that they can come share those outcomes today. In the past, as you well know, we have focused so much on financial outcomes, and we've looked at staffing and financial outcomes. And unfortunately, we have made some very difficult decisions or not very good decisions sometimes in terms of finance and staffing. But we know now that that can very much affect the clinical outcomes, the staff engagement outcomes, the patient satisfaction outcomes, the compliance outcomes, and everything as far as that goes. And we also know that if we don't pay attention to the outcomes and to balance the outcomes, then we don't have the financial outcomes that we need. We don't have the patient satisfaction outcomes that we need, and the story goes on and on and on. So our colleagues at Advocate Aurora are experts at looking at these balanced outcomes and making sure that it all goes together through systems thinking. Balanced outcomes gets us where we need to go today, but we also know that technology is very important. Integrated technology that integrates time and attendance, staffing, scheduling, and everything else that we can go to one place and look and see what's happening. And then also we have huge opportunities to leverage analytics and mobile technology. And we know with the crisis that we've been going through with fires in California and hurricanes in the south and the COVID on top of everything, we know that analytics and mobile technology is very, very important. And we also know that an enterprise approach where we have staffing and scheduling systems, the same system throughout the enterprise with many different departments on, gives us a lot of leverage and a lot of efficiencies that we don't have when we can't go across the enterprise. You also hear today about the standardization of policies, processes, and technologies that our colleagues have done very effectively to be able to pull everything together in one standard format to get the work done. We believe very much at API that people drive success. If you think about it, everything in healthcare happens because of people. And so if we can support people in their work and be able to do the kinds of things that they were born to do, we can make sure that we can have great outcomes for patients and for our organizations. We know very much that shared governance is the heart and meat of all that, especially when it includes the frontline staff. And the bottom line is, we are in this business because of patients. We are staffing because of patient outcomes. And we want to make sure that patients can come to our organizations and be safe and have excellence in terms of care. Our colleagues at Advocate Aurora will talk to us about that today, about how they've been able to really achieve excellence in outcomes because, we're thinking about patients and nurses and how all that goes together in terms of synergy. So without any more ado, let me introduce Dr. Kingston again and express our appreciation for all of you being with us. So take it away, Mary Beth.
Thank you, Carlene. Really appreciate that introduction. Good afternoon or good morning, depending on where your location is. We are all just delighted to be with you today. to discuss our approach to nursing workforce management. I'll provide a brief introduction, and then I'll turn it over to Margie Gavigan, who led the initial work in this area, and then Jane Dust, who coordinated and continues to be instrumental in planning our staffing efforts during the pandemic, which has just been, she's done a great job with that. As Carlene noted, there are many factors that influence effective workforce management, and there are many approaches to this issue as well. We'll share our work in this area, and it began, I believe it was over 4 years ago at this point. But I think the important thing is that we continue to work on reviewing and refining all the factors that are necessary to optimize nurse staffing. It's not something that we put in place and it's done. It requires continued attention and discipline, and that can be challenging at any time. And as Carlene mentioned, this is a particularly challenging time. So let me begin with a brief overview of our organization, Advocate Aurora Health. So Advocate Aurora Health is comprised of 26 hospitals and over 500 sites of care. And that includes outpatient clinics, medical offices, physician offices, and retail pharmacies. And then we have a very extensive home care service, primarily serving Wisconsin and Illinois. During this presentation, we'll be focusing on the inpatient setting for workforce management, though we recognize the interrelatedness of nursing across the entire continuum. And I think, this was particularly evident during the pandemic. We have 75,000 team members. That number gets bigger every time I see the new slide, but that includes more than 22,000 nurses and 8,300 physicians. We have a very strong employed physician network in both states. And then in Illinois, we also have it's a very innovative model, an aligned physician practice. So this slide just shows, and I'm not going to go into too much detail, but this is our strategic plan. And our purpose, I think, is very simply stated, but very elegant. We help people live well. And I know, to do that, nursing is just crucial to help anyone to live well and to achieve that goal. There's 3 key areas to our strategic plan, and I would say that workforce optimization impacts all 3 of those areas. The first is transforming the core, and that's the actual day-to-day business that we're in. It speaks to improving our outcomes, increasing efficiency, and improving financial health, as well as really facilitating our ability to grow. And, I think sometimes we forget about that in strategic plans as we look at new initiatives, that effective nurse staffing is essential. It's a foundational piece to many of the initiatives that are being planned. The middle pillar there is consumer first. I think we're all aware of the importance and the rising consumerism. I'd say the focus is on ease of access, so looking at other businesses that are 24/7 and ensuring that healthcare access is as well. We've had tremendous success connecting with consumers with a virtual platform called LiveWell that really improves the connectedness. It's not simply a one-way pushing out of information. There's an interaction piece that occurs that really engages the consumer, and certainly many other initiatives in that pillar. And then the last one is whole person health. And while that looks like a destination, we're really right now on that journey. This area focuses on new care models, again, where effective nurse staffing is critical, and also incorporating businesses and other initiatives that improve overall health. And again, I think nursing plays such a key role in that. So why focus on effective staffing? I mean, we could list the many reasons. For us, obviously, it aligns with our strategic plan. But, this has been a critical issue for nurses as long as I can remember. And more importantly, as research has clearly demonstrated, it's an important issue for patients and for people in every care setting. Effective nurse staffing supports the Quadruple Aim. We've talked about the fact that the research demonstrates that improves outcomes. There's improved satisfaction for clinicians, for sure, and that's not just nursing clinicians. There can be cost savings if done well, and that's a discussion we have with our finance partners, and it improves the patient experience. Again, and fairly recent research, Press Ganey did one that really linked many of these areas. So, for example, effective nurse staffing positively impacts nurse engagement which is highly correlated with patient satisfaction and positive patient experience. So again, these areas are all linked. Our vision here is, this is our vision statement, obviously, for effective nurse staffing. And it's pretty, again, simple. It's the right nurse at the right time with the right competencies at the right cost. And, you know, we've emphasized how effective staffing improves outcomes. It also improves the work environment through best practices, use of tools, use of data, and infrastructure. It does require an effective plan and then the ability to execute on that plan. You know, it's critical here to mention, and I know Margie will expound on this, but we do not view this issue as a nursing-only accountability. It's an organizational patient safety priority, and engaging leaders from areas that impact nurse staffing is essential. So Margie will be discussing how we need to pull, and we do pull in our human resource colleagues, finance, operations, IT, and I think because that use of data is essential. And as Carlene mentioned, our nurses and our nurses' view, because they are content experts in this area. And so pulling in frontline nurses to get their view of staffing is equally important. That it's just key. So the other reasons, many reasons to focus on effective staffing are certainly meeting the needs of the patient, a patient-centered approach that is data-driven and outcome-focused. But in order to accomplish that, we need to build in the flexibility because it is so multifactorial that there are so many things that can cause that variability, such as volume and acuity, and even in the nursing end itself, family leaves, absences, and we could list the many things that do occur. If we aren't able to be flexible, we'll never meet all of the pieces of that quadruple aim. So back a number of years ago when we started this, there was a reason for action. So you can see here kind of where we stood. Our team member survey and our AHRQ survey results showed we had significant opportunity in these areas. We were, and at times still do, spend a fair amount of time and resources addressing the gaps in scheduling, gaps in staffing at each site. The fluctuations that occurred, we were having difficulty effectively managing that variation. And then we were not consistently meeting our targeted nursing hours. Now, we know there can be many reasons that make sense for doing that. So we have the nursing hours, and then we have the cost piece. And I think, you know, in either case, it's a kind of a directional thing that we take a look at. But I get very nervous when people cheer when our productivity in terms of the cost piece is above 100%. We know that's not a good thing. And so that's been something that we've worked, particularly with our finance colleagues, on. But the nursing hour piece, given everything else, should remain relatively constant. And if we are having difficulty meeting that, we really did need to drill down and find out why. So before we move on, I have to add a disclaimer, and you will not be surprised by this. Our staffing is not perfect. So if you went into any of our sites and asked, I'm sure there would be a number of issues that were raised. We continue to work towards the goal of effective staffing. It means different things to different people, and creating that shared vision by inclusion is critical. What we've learned is that it's important to not drift from the primary principles that we all agreed on as a group. Over the years, we've had our ebbs and we've had our flows, but the good news is we have made and seen improvements. So now I'll turn it over to Margie to review the approach, the principles, and implementation. Margie?
Yes, thank you, Mary Beth. As Mary Beth has laid out, we definitely had our challenges based on our team member feedback. At Advocate Aurora Health, we do strive to be a high reliability organization, and an important element of that is to be consistent and reliable. And we clearly heard from our team members and our leaders that we had issues with significant areas of opportunity around staffing. So our goals with this work there were four. We wanted to consistently meet targeted, budgeted nursing hours. We didn't want to have any gaps or holes in our schedules, we wanted more efficient scheduling processes, and we needed to match our clinical resources to demand. So the 4 processes we focused on were budgeting, scheduling, deployment, and assignment. Now, in budgeting, it wasn't just about creating a good, realistic budget, but it was also important to have the processes around executing on that good budget. So we used certain strategies in order to improve these 4 processes. And this was, staffing is really a mathematical complexity as well as looking at process challenges. So when we started this work, we engaged a nurse scientist, a statistician, and a linear programming expert to look at historical ADT, payroll, and timekeeping data at the hourly level, and we looked over time. So that big data effort was well worth getting us to the models. The 3 areas that we worked on, we needed to optimize what our core staffing should be and what our flexible staffing should be. So many of our hospitals at the time didn't really have a large flexible staff. So part of this work was looking at our data over time and looking to see how we could match our clinical resources to demand and to identify the minimum core staff needed for a unit to cover their demand while supplementing with a flexible staff to cover the non-productive time vacancies and things like FMLA to consistently meet our targeted nursing hours. Another focus for us was looking at scheduling patterns and creating patterns to match the patient demand variation for every unit, while at the same time applying new system-wide standard staffing and scheduling practices. And we needed to do that to ensure reliability, efficiency, and also equity in the deployment of clinical resources across the organization. What we found in several of our hospitals was that we were sending people home on one floor and then, incurring overtime on another. So clearly we needed definitely a hospital view, and then also possibly, a regional view where appropriate to deploy staff more effectively. And then lastly, we looked at defining these deployment strategy, creating central staffing offices to address special cause issues like unexpected short-term low census, or and we married that with special call solutions, redeploying the resources to the needed units and then releasing high-cost resources. So these were really the strategies that we used to improve those 4 distinct processes. Standardization was an important part of our work, and standardization is always difficult to achieve. But so we really worked with our chief nurses at the sites, our nursing leaders, and frontline staff to develop staffing and scheduling practices, standard ones across the entire enterprise. And then we did leverage the use of our scheduling software to help us implement the care models that we developed based on that big data process we went through. I mentioned before that it's important, of course, to create realistic budgets, good budgets, but it's just as important to make sure you execute on those budgets effectively. And in our case, we found that we might have have created a very sound budget, but then we didn't have the HR processes around the budget to help us get to where we needed to be. So we needed to standardize and streamline our position approval process. We found it took us many days, and in some cases weeks, to get a position approved. And as we know in today's, a very fast environment, and needing, to have be nimble, we can't have several days. We have to have very streamlined, effective processes in order to get approval and then execution of our budget. So in a partnership also with finance, we developed nursing budgeting principles. Like any healthcare organization, we didn't have standardization in how we approached the nursing budget. So we did develop with our finance colleagues standard nursing budgeting principles to help us approach the budget in the same way. We also synchronized scheduling timeframes across the system, and we were fortunate to have a standard scheduling system for the hospitals that we worked on this with. So we did have, that was already, the technology was standardized, which really helped us. We also developed standardized job descriptions for all the flexible staff and the staffing office personnel. We also created the site and system multidisciplinary ecosystem, which I'm going to go a little bit more into further in the presentation. But what Mary Beth mentioned earlier, staffing is not just a conundrum for the clinical leaders and non-clinical leaders who have to run departments. It really needs to be a joint effort to ensure effective staffing. It's that joint problem solving with other clinicians, creating structure and changing processes, and then tracking key metrics that really makes the difference if you can achieve optimal outcomes. So here's an example of what our ecosystem teams are, and we have them at the site and we have them at the system level. And you can see clinical leadership, finance, IT, HR, and clinical education makes up our ecosystem. Partnerships with other disciplines we know are critical for the development and sustainment of the solutions to a complex issue like staffing. So when we look at clinical leadership, what they're responsible for, it's really the development of strategic staffing plans, deployment of tactical strategies, and ensuring the safe and effective staffing plans. Also, of course, the change and transition management. With our finance partners, we looked to not only develop those budgeting principles, but also system-wide development of budget assumptions to reflect actual performance. We also needed our finance leaders to support the new staffing configuration plans we had, and to also support the HR processes that we put in place. They also provide analytics to help us to maintain alignment of our models. IT was also critical, developing infrastructure and processes to support a system implementation of our staffing and scheduling standardized practices, and also to help us with proactive planning and delivering on enhancement. As Mary Beth mentioned earlier, we started this work several years ago, but year over year we make improvements in all the different areas, and we challenge ourselves to say, how could we do it better? With HR, the partnership is really, we need a proactive and innovative recruitment for our vacancies, for core staff and flexible staff. And we need our wage and salary practices to that they're in line to attract and retain staff. We also need them to help manage risk with our staffing and scheduling practices. And then clinical education is obviously another important part of our team. Efficient and effective onboarding. They facilitated cross-training across our system. They developed the flexible staff, enterprise, and regional orientation. And again, they demonstrated agility when we had some common cause changes that threatened the entire ecosystem. So I think this is one of the most effective strategies we put in place, and it's been in place for several years in order to effectively get to those outcomes that we wanted to achieve in effective staffing. Now, all of this type of work, and as Mary Beth talked about earlier, it's ongoing. This is, it's a journey, and we're constantly trying to improve upon ourselves. And as the saying goes, no one likes change, really, but a wet baby. And I can tell you that taking on staffing and scheduling is a tough business. But as leaders, we are often torn between our past priorities that are still important and new priorities to help us continuously improve, to keep a competitive advantage. And when leaders change, we must understand that stability versus change is not a problem for us to solve, but really a polarity to manage. So in order to execute and sustain these strategies for effective staffing, we partnered with our HR and organizational development colleagues and used our organization's change management framework to build our case for change. That was extremely important in the effective execution of this strategy as well as the sustainment. So we were able to employ tools, things like stakeholder and impact analysis, communications and change plan tools, a readiness assessment, and then a sustainability plan in order to make this effective and execute. I will tell you, it took us a longer time, taking this kind of approach, but the results really and the sustainability were, validated our effectiveness in using this. And even though it took us longer and it took a lot of engagement at the site levels with all levels of the organization, it was, I would say, one of the most important drivers for our success. So what did that change management, change leadership focus do for us? It helped our leaders and staff have a solid understanding of why the change was happening. We did leader training to help develop the mindset and the skill sets and also the tools so that our leaders could be effective leaders of the change. For some of our leaders, this was the first time they had used a change management framework. We also developed a coalition of support among leaders of all disciplines who were involved that created momentum throughout the organization. We did, of course, identify our resistance, and we dealt with it early in the process. We had senior leaders demonstrate their own and their organization's commitment to the change. So when we started the leadership change management training, we started in the C-suite at all of our hospitals to ensure that our senior leaders could effectively lead this huge change process. Communications were segmented and they were customized for different audiences. And the organization, through this, really for us, it was a culture change. It created an excellent backdrop for our next change initiative. And we all know that if anything is constant, it is change for us in healthcare and as healthcare leaders. And there's been many articles reported on, the advantages of using a change management framework. But one that was recently reported in Project Management Institute is that they reported that organizations that are highly effective at change management are 117% more likely than less effective organizations to report success with new initiatives. So there is, good evidence out there on the importance of using a change management framework consistently across your organization for new initiatives. So in the very beginning of this webinar, Carlene Kerfoot talked about balanced outcomes. And I just wanted to share the outcomes that we look at the system and at the site level as part of the sustainability of the work and also to advance the work. And just as Carlene referenced, it is a balanced view. So we track financial satisfaction, HR, and quality and safety outcomes. And that is definitely what we need to do to make sure that our strategies around staffing are effective. And then there's technology. And again, Carlene talked a little bit about this in the beginning. This was an important part of an enabler of our strategy, looking to empower accountability with analytics, putting data in the hands of the decision makers. It also afforded us enterprise-wide visibility and transparency, and it also helped us facilitate standardization. But I think an important point is the technology alone cannot do this. It is the structures that you put in place, the standardized processes, and the change leadership along with the technology together that really makes the difference. So at this time, I'm going to turn over to Jane Duz, who will talk about our recent effective staffing vision in times of COVID-19.
Good afternoon, everybody. I wanted to echo the sentiments of my colleagues on how excited I am to be here and to really share the journey that Advocate Aurora had at the initial onset of the pandemic and as it continues to impact us today. So before I move on, I really wanted to share with you a snapshot of really what happened at Advocate Aurora during the pandemic. I know we're still in it, but really at the height of it. Our communications team put out daily updates in terms of system tracker that we shared with the system and the individual sites that really gave an overview of what was going on in the system, really for awareness. And this is a snapshot I think I pulled from the end of June. But my point in sharing this is that the COVID-19 virus and the pandemic did hit Illinois and Wisconsin pretty hard, particularly initially in the Illinois and greater Chicago area. And during the height, April, May, June, we had as many as, greater than 800 patients that were COVID positive in our hospitals. And today, we're still hovering around 220, 230 patients that are COVID positive, and we are starting to see a resurgence in the Wisconsin area, particularly the North Wisconsin, to the point where we may end up opening up our system incident command to help manage the volumes in the North. To date, since the start of the pandemic, we've had over 27,000 COVID positive patients through at the Advocate Aurora hospitals, and that includes over 1,100 fatalities. We also have had a fair amount of team members that have been that have tested positive and that have been on quarantine. And another point in terms of some of the innovative strategies that Advocate Aurora used to approach the COVID pandemic, our Advocate Christ Medical Center, which is located in South Chicago, it's a teaching hospital, and they are tertiary, quaternary care. At one point during the height of the pandemic, their cardiac surgical unit had close to 35 patients on ECMO. And you heard me right, close to 35 patients on ECMO. 8 to 10 of them would have been there anyways because of their cardiac problems, but the remainder were there because of their COVID positive status. The majority of these patients were between the ages of 20 and 60, and the amount of resources it took to maintain that was incredible, but we were able to do that. And in fact, there has been an article already published by the lead cardiac surgeon on the positive impact of managing COVID in this population. So my intent in sharing this is to say that COVID did hit our sites hard, and we had to react in a very quick manner. So with really a strong workforce management strategy already in place, thanks to the work that Margie and our colleagues had, we really were well positioned to quickly and effectively respond to the COVID-19 crisis. I think a few things to highlight that we started is that because we did have this workforce management strategy in place, we're able to optimize that. Both states of Illinois and Wisconsin did relax licensing requirements so that we were able to move team members across state lines. We had many of our nurses from our Milwaukee St. Luke's Hospital come down to help support our Christ Hospital with their ECMO patients. We had nurses as far north as Sheboygan coming to help us in Chicago. So it really was a group effort, and the licensure relaxation did help, although it was a very quick way to get a temporary license. We also did, much like many of the country, have to close down our elective surgery and our ORs. And so we were able to reassign many of those furloughed team members to new roles. And we are a large organization, and we've estimated that over 5,000 new team members were reassigned to new roles. And these roles included screeners. We know we had to start screening team members when they entered the organization. Runners to help. We had massive increases in our calls to our COVID call centers. We needed nurses to help our contact centers with triaging patients to the right level of care. We had a big demand for HIT, even something as simple as setting up iPads because they went to a virtual model, virtual visitation, virtual hospice and support care. So we need help setting up those iPads to get them out there. We also had a lot of requests for HIT and data management. Both the state and the State Department of Health and the Government Department of Health had, as you know, increased the reporting requirements for data around COVID patients. So we brought people into help with the reporting requirements. And we also reassigned many of our caregivers to employee health because employee health was just overwhelmed with managing the response to this pandemic. So the first thing we did was we really created a system virtual labor pool because we did have most of those people at corporate or who would have been available on the sites were asked to remote work. So we did create a virtual labor command center. And this virtual labor command center was led by myself and my HR colleague who oversaw talent acquisition. And we were able to pull together subject matter experts and people who really understood staffing and could help us from the different areas. So within really a few weeks, we had created a 24/7 online process to request and reassign staff. We were working very closely. Each site within our system had set up a labor and incident command, and they had a designated labor pool person in that incident command structure. We created a database of available team members, and we also reached out and allowed team members to volunteer for reassignment and really just giving them that option. We had many team members step up and be willing to go help out where they could. The other thing is that we also knew that life doesn't always stop, and we continued to bring on new hires and new nurses and new respiratory therapists, but we also needed to help those nurses who were furloughed. So example, those nurses who worked in the recovery room, the PACU, the OR, they may have worked in an ambulatory setting. They were mostly furloughed, but they had that skill set and that nursing clinical background that we use. So we did two things. We created a virtual nursing, we moved our nursing orientation to virtual, and we also moved our nursing grad residency program virtual. But the team of the nursing education professional development specialists and the whole nursing professional development team did a phenomenal job in quickly pulling together what we call their SOS program, or surge orientation staffing. Again, it was a virtual online program to help those nurses who hadn't worked at the bedside for a while or hadn't worked in an ICU for a while. So we created a program for them to do a self-study to go in and relearn and help refresh that was then supported at the bedside when they went to work at the bedside. And we even partnered with our simulation team to help do some simulations on things like team-based nursing, et cetera. And that was really well received in terms of the work that was done to help prepare those nurses who were not necessarily familiar with the area that they were asking to be reassigned to. I also alluded to the fact that we did develop a team-based nursing model. And we know that sometimes the old-time term of team nursing may be a euphemism for reduced staffing needs, but in this case, our team-based model wasn't necessarily due to reduction in staff, but it was really to adapt to the skill set need. So we had these nurses who may have been out of the bedside for 2 years, 5 years, or they've only worked in the PACU, or they've been in ambulatory for a while. They have that skill, but not necessarily the refined skill set to work fully independently at the bedside, caring for a COVID patient, or working in med-surg, or working in ICU. So again, we pulled together, and this was a lot of the work done by the nursing education and professional development team. They pulled together what a team-based nursing model looks like, and we had classes and courses virtually to help the managers understand it. And it really was our approach to help stretch the skill set, knowing that one med-surg nurse can't necessarily take care of 4 patients on their own, particularly if they haven't worked in an area for a while, but maybe a med-surg nurse and one of our reassigned nurses could take care of 6 or 8 nurses as a team together. So it really was managing the skill set. The other thing that was, I'm sure everyone on this line experienced this, is that the rapidity of change that impacted the nurses was incredible. We moved from respiratory therapy, doing some inhaler treatments, nebulizers, to the nurses doing it to minimize the exposure to the patient and use of PPE. PPE policies were constantly changing and being updated. We changed documentation policies to make it easier. We counted that over the course of the initial surge, over 300 different nursing practice changes were occurring in our organization that we had to track and update. And again, really strong partnership between our nursing practice colleagues and our nursing professional development colleagues. We also created, in terms of supporting practice, numerous COVID-19 educational videos that were available 24/7 or in conjunction with a QR code that it was just in time in the event they needed to look at. I'm not sure how to use this PAPR, I'm not sure how to use this ventilator hood, et cetera. So we really created some just-in-time training materials as well. The other thing that we did as an organization, we consciously committed to and made the decision to look at paid practices for caring for COVID patients. And there were some other organizations in the Chicagoland area that were doing this, though not all, but we felt that it was our mission and our obligation initially to implement COVID paid practices. And so we identified two different types of COVID paid practices, the one being continuity pay, the other one being COVID-19 pay. And it was really based on different triggers and volumes and percentages of COVID units, overall percentage of COVID patients, the penetration of COVID positivity in that region or that area. And if it had met our certain triggers, there was an across-the-board increase to all employees, all team members of that organization. And the increase was really based on what work they did and what skills they had. We didn't implement that at many of our organizations because they didn't hit that trigger, but we did have organizations where across the board there was a pay increase. But we also focus COVID pay on those people, team members who are working specifically on a COVID unit or in an area where more than half of the patients were COVID positive. And that was, again, a per hour increase, again, based on what work you did. And that was implemented at many of our organizations since we had some sites, almost all of our sites had some form of COVID patients. Since the surge and with now integrating the care of the COVID patients into our routine care, the COVID paid practices were eventually sunsetted and sundown, and as of last month, we no longer offer the COVID pay. But during the time, it was really well received. I think it was the right approach, but you can also imagine how difficult it was to manage and adjudicate. I wanted to give you, I've alluded to this, but I wanted to give you a real quick snapshot on the nursing education and professional development team because, A, that's my department, so I have to really root for them. But we had also, just at the start of the year, post our merger and integration, we reorganized how nursing education and professional development looked across our footprint. And the way we had that structured really helped support that we could be there to help during this pandemic. And this slide just really gives you an idea of how much work that team did in supporting our frontline team members, helping orienting frontline team members, onboarding team members. We brought on so many zero hire assignments, and zero hire nurses and new hires. The onboarding didn't stop. And the continuous update of material that went out to our team members was really incredible. And a lot of the work was led by this team. The other thing, it was very important to our organization to be as transparent as possible and to have timely communication. Our public affairs and marketing team did a phenomenal job in really putting out daily updates and daily trackers. We did set up very early on in March a system incident command where there were daily calls. We also had initially, this is listed here as 3 times a week, but every day, those first 2 or 3 months, we met daily with the system nursing leadership to address issues, answer questions, follow up. We had a dedicated COVID information center and a toolkit, and our ongoing response was, please read the toolkit because so much information was updated, and it was a really good source of information that was kept up to date. Our CEO and senior leadership did weekly videos to keep our team members apprised of what was going on. Their team member and leader communications came out weekly from our public affairs and marketing. And then obviously we had the site incident command and system huddles really to identify issues. And those were turned around very quickly through the incident command process. And so I do think having a strong staffing approach helped. us really manage this surge. And we do know that skill set is important, and I failed to mention that even though we did have access to furloughed individuals, we still ended up bringing in about 150 contingent labor agency nurses, because we really needed a focus on strong med surge, and particularly those that could really help out in areas like the ECMO. So we are still in the still managing, still prepping for additional staffing surges, taking those lessons learned from the immediate surge and how we can apply it. And like I said, we're seeing another surge in our North Wisconsin market, so we'll be taking many of these lessons learned and applying it to our markets that are really being hit for the first time up north. And I think we have really set the foundation to continue to be successful. So Mary Beth, do you want to wrap this up?
Sure. Thank you, Jane. I'll take it from here. Great summary. So I think what you can hear is that Margie talked about the strong foundational principles for staffing, scheduling, and the collaboration that needs to occur. I think one of the things as we look to the future is ensuring that we don't drift from those principles. But at the same time, the lessons we've learned throughout these past few years, but specifically during the last 6 months, is that we've got to have flexibility in the workforce. And if these top two, the flexibility and sustaining new skills, and Jane, you didn't mention this, but I know you're living it, it's a lot harder to do than we think. In the times of crisis, people step up and everyone comes forward, and we had a great supply of individuals who could be reassigned. As we move forward and we balance, continuing all of our business, all of our activity, all of our elective work, while we're continuing to care for patients during the pandemic with COVID-19, people want to be at their unit. They want to be at their site. But we're learning, and we have a number of our pools where people go to different sites, that flexibility, that really stretching not just your in-house pool, but stretching your pool to be able to move your resources to where you need them is critically important. The sustaining new skills is much more difficult because, as we've discussed before, the people that we need them in their current roles, and it's easy to say, oh, we'll just have someone, one day every other week go and work in the ICU, but much harder to operationalize that. So trying to look at different ways to be able to help people maintain some of the skills that they did pick up and that they did, incorporate into their practice during the pandemic. Certainly continued stronger relationships with team members. And, in Illinois, it's required that we have nursing, I think it's 50% of our frontline team members in staffing committees. And that approach really works. When our nurses are involved in making the decisions, they can go out and help support that. And we've implemented that in Wisconsin as well. And then, of course, as how Carlene started our whole discussion, having that balanced outcome, that just requires, we like to say we educate finance, but they also feel they're educating us. And the reality is we're educating each other about the importance of balancing finance and cost with quality and safety. And many times, and this is something we all need to consider, many of our benchmarking tools don't incorporate a quality measurement along with that. And that's something that I think we all need to champion. And that is, yes, we'll benchmark, in terms of the cost, our staffing, but we need to see how it relates to the outcomes as well. So with that, I'll turn it back over to Brian.
Thank you so much, Dr. Kingston, and thank you, Margaret and Dr. Duz and Dr. Kerfoot for that excellent presentation. And we will now begin today's question and answer session. So as a reminder, please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we can. Dr. Kerfoot will be leading this Q&A, so I'll turn it over to you, Dr. Kerfoot.
Great. Thank you very much, Brian. We have several questions about how you do this. And the first question is, do you use a centralized or decentralized model to create schedules? And then also, what about filling open shifts?
So, Carlene, I'll take that. This is Margie. We actually first do a decentralized on the unit, and then bring it centralized into the staffing office. And then, so we start out with decentralized and then look at centralized. So it's really a hybrid. It's a combination of both. We do force the function in our scheduling software, though. So we have A and B scheduling groups that rotate off every 6 weeks. So so A goes first, and then B becomes A in the following, to promote equity. So we force the function in order to get balancing of the schedule right away. If we require 6 nurses at 9 o'clock on a Saturday, we only let people schedule up to 6 people. Then you have to move on and look for another day to work. So we do, to try to make it much more efficient in the scheduling process. We do force the function, at the unit, and then we bring it centrally, whether we're talking about the hospital or we're talking at the system level.
Good, thank you. We have another question. What do you mean to be flexible? Does that mean that you require RNs to float to departments other than their home departments?
Oh, I'll take that one.
So
and then we can all jump in. By flexibility, we're actually exploring people coming on board and agreeing that they are going to go to additional sites. I mean, this is not something that we only do that now in our regional pools, but we found that this ability to have people comfortable, not just going to different units, but going to different sites. Certainly there's the whole competency issue and all of those things that we have to consider as well. But having more flexibility, I think, is going to be key moving forward. And now it might have been Jane or Margie that was jumping in.
It's Margie. Yes, definitely. I think one thing to understand is when we did our big data analysis, we really changed the way we did budgeting. So if you were a unit that had 25 nurses in your budget for FTEs, a portion of those nurses were now going to be flexible based on your census variation. So we would actually, as Mary Beth said, hire into maybe 20 FTEs were core staff and 5 were flexible. Those nurses were hired into those positions, and they knew they were going to be the flexible staff. And we could onboard them that way, and it really increased team member satisfaction, because there are some nurses who do not want to float, and we did pay a small incentive for those nurses to move across their float pool groups.
Yeah, and this is Jane Does. I do want to mention, though, both legacy sites, Advocate and Aurora, had slightly different approaches to a float pool model. And on the legacy Aurora side, there is a very large system float pool for the greater Milwaukee hospitals. They go to, I think it's 8 different hospitals. And we have about 120 plus FTEs in there between nurses and nurses' aides. And that was incredibly helpful during the surge as well, as opposed to Illinois side, where they have these very strong flexible work pools that Margie referenced.
Good, thank you. We have another question. Do you have facility staffing councils? If so, what are their goals and how do they help address staffing issues? Who wants to take that?
Well, I can start,
Margie,
Carlene.
Yeah.
So we have nursing care committees. We are bound in Illinois. We have some state regulations where we need some structures in place, but actually we have a very strong shared governance model at the system level and at our site levels. So the frontline nurses being involved and having a voice in staffing is critical to our strategy. So we leverage our shared governance framework, and we do have nursing care committees that have standardized agendas. We bring the budget, before we create the budget, they have a say in, what the nursing hours should be. They study, we bring data to them, and ultimately, it is the chief nurse's responsibility, but yes, very much we have engagement from frontline staff in both states in order to, create the budget.
And we're going to be replicating that process on the Wisconsin side, as there's no regulatory from the state level, but we want to be similar in terms of how we approach it. And I believe it's important that these nurse staffing committees do help with nurses really understanding the process.
Good point. Very true. Another question, what did you learn about change management during this initiative that will help make future changes easier? I think that was a very great presentation about change management, but lessons learned, what will you do differently? Margie, that's probably yours, right?
Start.
Yeah. Poor Margie, all the questions are for you.
We talk about change management, change leadership is another tool we all as leaders need in our toolkit or on our tool belt. It's really, a necessary skill. And, if I could just speak from personal experience, every time I utilize the framework, the change leadership framework that our organization uses. I know as a leader individually, I get better at it, but also I think as our teams get better at it. So I think we learn that, and it's a discipline. It's really sometimes as leaders, we want to go quick to the answer, we want to go quick to the implementation, but without really taking that disciplined approach. And I think that's what we learned in doing this work and using the framework and using the tools. You really do not get the sustainability and change of the initiative. So we learned that it's well worth putting the time in. No change leadership or change management framework is better than another, as long as you use, a validated one and that has good tools. So we learned that the more we use it, the better we get at it, and the faster we're able to implement change across the enterprise.
I would just add one thing to that, and that is during the whole pandemic process, the other thing I think we learned is just the communication piece and having forums where people can ask their questions and get answers very quickly. That helped us move at a speed that we had never moved before, and it's actually caused us to shorten up some of our meetings and maybe make them more frequent to bring people together more often to have that dialogue. That's a big lesson learned for us.
Good. Someone wants to know about the percentage of represented nurses in your organization. And if you are highly represented, how are you managing multiple worksite arrangements with labor?
I can take that one.
Okay, go ahead, Mary.
Yeah, go ahead, Jane, because you have it. Go ahead, Jane.
We only had 2 hospitals that have nursing unions, and at that, they're both very small. So, and it really hasn't been an issue in terms of the COVID pay and them moving around. And in fact, I don't think either of the sites actually had staff move around, so it ended up being a non-issue.
Okay. Well, I think our time is up, and I think we have had some very interesting questions, and thank you for those answers. But above and beyond that, we really do want to thank you so much for your time and effort to be able to share all your expertise and to be able to tell other people how you do such a good job and how you're so widely recognized in the nation about achieving excellence. So we thank you very much, and we do want to say at API Healthcare, we are very privileged to be able to work with you and to be able to partner with you and to be able to do the staffing, scheduling, platforms, and things that we need to do for the future. So we sincerely do appreciate that, and you can just see what great work you people are doing. So from the bottom of our hearts, thank you very much for everybody who joined us today, because we know that you are very interested in this and that you want to really excel in this. And we thank our partners from Advocate Aurora for being able to participate in this and share your expertise. So thank you very much. Appreciate
Thank you,
that.
Carly, and everyone.
Mm-hmm.
Thank you.
Mm-hmm.
Yeah, on behalf of Becker's, I just want to thank all the presenters again and the attendees. It was a very engaged group, and I think that speaks to the quality of the presentation. So thank you, everybody, and thank you to Simpler API Healthcare for sponsoring today's webinar, and thank you to our attendees again. Enjoy the rest of your day, and we look forward to having you join us for future webinars.